And we're here because my beautiful friend, Nancy Davis, who is fearless in all aspects of life, brought together this incredible panelists, including research specialists, along with women like Nancy and her daughter who have directly been impacted by this truly devastating disease. So before we get into the actual interview session, I wanted to have everyone introduce themselves. So we'll start with the doctor side.
Oh, no. Okay. My name is Adam Kaplin. I'm a neuropsychiatrist trained at Johns Hopkins. I'm here predominantly because I will follow Nancy wherever she goes. She's one of the bravest people I know. I was involved in the MS. I am involved in the MS Foundation, and she has been a champion of the above the neck symptoms like depression and the like. So this is relevant to me. My family has lost someone to fentanyl, but I'm here because I will do wherever you go, Nancy. I want to be part of that battle.
Dr. Dunn?
So I'm Kelly Dunn. I was at Johns Hopkins for 15 years until recently, and I've moved over to direct the Collar Institute for Addiction Medicine at the University of Maryland. I got into this field because as a child, I saw people affected by addiction, and I've just felt very compelled to find solutions for those people. I'm very grateful to be a part of CAN. There's very few people investing in addiction science and research and trying to really get out in front of stigma and make a difference. And so I'm always just very appreciative of the opportunity to come and talk to people.
Hi,
Yeah.
I'm Isabella Rickle. I'm Nancy Davis's daughter. I'm so happy to be here. We helped find CAN, and I'm just, very passionate about working on this charity. And I also started in high school a subsection called You Can Save a Friend, which works towards educating young adults and teenagers about addiction. And
Amazing. You're blessed, a beautiful girl. Nancy, who needs no introduction, but let's go ahead and just give us, your elevator speech.
I'm Nancy Davis, and I'm so happy everybody's here. We're on the eve of having our first Cure Addiction Now event. It started sort of during COVID, and we couldn't really have an event. This is my son, Jason Davis's dream that we would all be here with brilliant scientists, brilliant-minded people. He had an addiction. He was addicted to heroin, and he didn't have a drug till he was 21, but he had his first drug, and he was obviously one of those susceptible people that when it hit him big, and it ruined his life. It was awful. It also ruins the life of everybody who loves that addict. It's a really big family disease, and you can't ignore the fact that if you love your child, which most everybody loves their child, and you see your child hurting and sick, and you don't have the tools to help them, you don't know what to do. It's the most devastating thing. Jason came to me one day and he said, "Mom, we're going to start a charity called Cure Addiction Now." And I said, "Oh my gosh, we are?" And I'm like, "I'm so busy." He goes, "Mom, you don't understand what we have done for MS, and that there's now 25 drugs on the market with FDA approval. We need to have FDA approved drugs. We need to look at everybody. AA is great, and if it works for you, that's amazing." But he goes, "Mom, it doesn't work for me. I've tried it so many times and I keep failing, and I feel really bad about myself when it does not work for me." It works for 7% of the people. So what do you do with the other 93% of the people? You have to come up with other things. Addiction is so many different diseases all lumped together in the same area, and not one size fits all ever. That's not going to happen. I'm here today to say that I'm thrilled to have this amazing group of Cure Addiction Now. We have funded 19 studies. We have a long ways to go. For 25 years, nobody was funding anything that had to do with basic science research with addiction. That's just inexcusable. I think we're getting smarter. We're looking at this differently, and I look for the greatest opportunity to open everything up. And I am bound and determined to be one of those soldiers that wins at this terrible fight. And we are going to find a cure for addiction now.
I think if you know Nancy, you don't ever say no to Nancy because she'll just find a way. And that's why we love her so much. Lisa, who I first met because she was following me to learn how to be a journalist on a TV show that she was going to do. So she was my shadow for the day. Right. And I'm glad we're back together. I'm sorry for necessarily the circumstances that brought you here, but so glad that you're here to share your story.
Thank you. Yes, thank you, Lisa. My name is Lisa Vidal Cohen, and I am an actress, but I'm also Scott Cohen's mom, and who also I lost. It's not easy for me to not cry. I'm here. Thank you to Nancy, because the way we met is kind of crazy, but I know our boys brought us together in heaven, because my son was also a beautiful young man, brought up by a beautiful family, loved dearly, was injured and put on oxy, and became a terrible heroin addict. And he fought for his life. We fought for his life. We fought for our lives. And then he took his own life because he couldn't take it anymore. And I have prayed and asked God to show me, what do I do with this pain? Where do I put it? Who am I now? I have to overcome this and get through this and honor my son. And then I know that Jason and Scott got together in heaven and put Nancy and I together. And I was like, you're what I've been praying for. You are the one. And I feel incredibly fortunate and blessed to be working with Cure Addiction now with these incredible people. And I am hopeful. I am so hopeful for Nancy and Cure Addiction now and all the doctors and all the people working on this to save lives and change lives. And I'm a fighter too. I don't give up. And so I have found my new sweet girlfriend who inspires me and just encourages me always. I'm really proud to be here. Thank you.
Thank you.
Thank you. Thank you for sharing. Megan, I know you may recognize her voice from being on the radio here. You also have a very personal story that brought you here.
Yes, so my name's Megan Holiday. I'm an on-air radio DJ at K-Rock, and I'm an alcoholic. I'm an addict. I just celebrated 9 years of sobriety in January. Thank you. Thank you, guys. Also, heroin addict. Your story is so, touching. I'm so glad that you're here. And I did, I'm sober today because of 12-step recovery. But like Nancy was saying, it may not work for everybody, right? So we're aligned because we want the same things. We just want people to stop dying. We just want people to find recovery and to get better. So any means that we can make that happen in this world, I'm all in for that. I also started a nonprofit organization about a year and a half ago. We're called Life of the Party. We hand out Narcan, which I'm sure you guys saw some on your seats, which was provided by CAN. And we give out fentanyl testing strips, and we go out to, different music festivals or just community events, and we train people on how to use it. And we just want to empower people to know that, we got to look out for each other. Fentanyl has found its way into basically every single drug out there, including fake prescription pills, So you have these young kids that might just be experimenting for their first time, and they take a pill, and the next thing you know that they're dead. And that's just not okay. So when I am teaching people on how to use Narcan, I just always say, you can be the hero. You get to be the hero. So I'm just very honored that I get to be here and a part of this panel, and just to be able to, give insight, like literally being an addict and being able to sort of give insight into how that is to be like that. So thank you so much.
Thank you, Megan. Thank you so much. And last but not least, Dr. Herring, thank you for being here.
Hello, my name's Andrew Herring. I'm very much a physician on the front line of the opioid epidemic. I work in Oakland, California. Part of why I'm here is that I went to Harvard Medical School and then came to Oakland, and very soon my practice in the emergency department was just full of people struggling with substance use disorders, opioids and others, and there's just was nothing for them. There's good science, there's good treatments, there are things that work, but it wasn't getting to the people who need it. And so with that, we founded something, myself and some others founded something called CA Bridge and Bridge, where we're really dedicated to bringing high quality evidence-based treatment developed by incredibly, brilliant scientists, like we have here today, to the people who actually need it when they need it. So we really can, save lives in real time. And the incredible group of people that Nancy's brought together here with Cure Addiction Now is just such an opportunity to bring science and policy and practice to really change things quickly. So I'm just really happy to be here.
Thank you, Dr. Herring. One thing that I was really surprised at when I was doing my research for today, that last year, 112,000 people in the US alone died from their addiction, and that 6.1 million suffer from opioid abuse. And it just I couldn't understand or wrap my head around, why is this still being allowed to happen? It's the leading cause of death for people, teenagers to their 50s. Is who wants to address that first, I guess?
Geez, well, I'm going to say that I think that the bigger issue and why this is happening is because addiction is something that people look down upon, especially in this country. We don't address it as a disease, as an illness, as someone who is suffering, just like someone would be suffering from cancer or brain disease. And a lot of times, like Nancy was saying, it's more than one disease wrapped up. A lot of diseases wrapped up into one, where it's like mental health issues. One either feeds the other, or one starts with mental health and then they start using something because they don't know how to deal. And I really feel that this country does not address it in a healthy, loving way. Instead, we as a society look down on addicts as if they're losers, and they're the unwanted ones, and they're the ones that are bad for this country, or it's a bad look, or as a family, just our family in itself, I started feeling like, geez, people are looking down on us because my son is a drug addict and he's sick. And then, I found myself, people acting weird with me or uncomfortable. And Nancy and I talk about this all the time, how, we're good family. We're, we love our children. We loved all our children. And, my son did not start out as a bad person, and so I think that that's part of the big problem, that people hide. They feel they isolate themselves. They're afraid. They're ashamed. And then they keep using because they take on the identity of the loser. Mm-hmm. They start believing how people see them and what they say about them. And I know a lot of people just, they get so sick that they just want to die. And they just use more and more until they hope to die. And it's horrible. And I believe that that's why we ignore it, just like we ignore mental illness in this country. And that's what Nancy and I are hoping. Well, as one of my girlfriends, because we have such similar stories, that it's like we got to do something. Let's do anything and everything we can to raise awareness and to take that stigma away, that shame, and that big lie that addicts are losers and they're bad people, because that's just a big fat lie, and it's so not the truth in most cases.
No. And I think when you look at trying to treat it, and we say, oh, what about a rehab center? You have to have oodles and oodles and oodles of money to be able to afford going to rehab. And why is that? Why is it not taken care of, like if you had some other disease?
Yeah, so to me, it makes as much sense as, so I never met a cake I didn't like. So I have, enjoy sweets too much. It makes as much sense as if those cookies over there were illegal and I had to sneak them because I had an addiction to eating sugary, fattening things. That makes as much sense as these drugs, which have been invented over thousands of years. They are the most addicting drugs ever invented. So it's not, it's not easy to manage these things. And as a medical profession, we have failed. We actually got the epidemic started by not knowing how to manage pain. Now the genie's out of the bottle, and it is very difficult to treat an illness that is not considered an illness. It's considered a part of a war on people who use it. People who use these drugs are labeled criminals as opposed to patients. It's that absurd. And so, what you were talking about rings a bell with me as well as a psychiatrist. Only, even though, drugs cause depression, depression causes people to use drugs, at most in these rehab facilities, 10% of people will get treatment for both the mental health side of the substance use problem. So, it's many different aspects, but that's just a shot across the bow. And I'll let my colleagues who are frontline address their perspective.
So I think another element of this is that addiction is inherently we call it a chronic relapsing disease. So it's a disease, it's an illness, and the expectation is that people will, there's lots of different pathways into addiction, and often people develop addiction before they realize that's what it is, right? And so then they once they do get to this point that it's severe enough that they understand that they are suffering with an addiction, they're scared to tell people. They try to deal with it themselves, right? We hear a lot of, I got myself into this, I can get myself out of it, but it's a disease, it's an illness. And any other medical illness, you would feel, we hope that you would feel empowered going to your providers and asking for help, but people don't feel that way with addiction. And so the other element that makes it more challenging, again, it's called chronic and relapsing, meaning that we have an expectation that when you are treated, that it may come back. And other diseases do that too, right? Depression does that, cancer can do that. But the expectation when people go to treatment for addiction, they often feel that they should be cured. And if it does come back, they're scared to tell people and it becomes problematic for them. And so I think, broader understanding of the nature of addiction and how people develop it, what it's actually, that it is a medical illness that can be treated, but we have to treat it, and giving people some grace to come back and say that it's come back and they need help again, and kind of empowering them to do that would really help people.
I just think about the first time I learned about Suboxone or buprenorphine. I was an ER doc. And I went to go figure out, like, okay, how would I offer this to folks in the ER? And I got a little grant, and I wrote a 67-page document on how to do this. And I look back at it now, and it was basically the whole thing was just wrong. It was full of red tape and barriers and details that were not needed. And we've just spent the last 5 or 10 years just throwing things out one by one to try to create something that's responsive and easy to access. And that, to me, is just the big piece of what we haven't done. And the thing that separates this opioid epidemic from any other kind of epidemic we've had around substances is just the number of people affected. This is, in the history of humanity, there hasn't been quite this scale of people exposed to opioids at this level. And what we never did, the feds didn't, the states didn't, the healthcare systems did, no one actually pivoted to be like, okay, how do I actually create a system that brings evidence-based effective care to people at the same scale that they're suffering? No one really seriously even asked that question. And I would argue that they still aren't. And until we go there, how do we go big? How do we make this so? Unfortunately, it is part of American society. Every single person, every family basically in America has someone affected by this. Unless we scale up to that level, we're going to be struggling with just unbelievably high overdose rates every year. Even if they tick down, they're still just incredibly, absurdly, horrifically, scandalously high.
Is it worse in this country than in other countries?
Absolutely, by orders of magnitude.
Why? Why do you think that is?
Well, the key thing is just exposure, right? I also remember as a early, person working with pain in the ER, learning about opioids, and then kind of seeing the drawbacks they have to pain, and then trying to figure out how much Norco is being prescribed, how much oxycodone is being prescribed. And those numbers were not easy to find, right? And then when I found them, they looked like a conspiracy theory. it just didn't seem plausible that 1 trillion tablets like could be produced and distributed and gotten into people's medicine cabinets in every single county in the United States. This was boardrooms and execution of plans. This was just this industrial scale event that literally has never happened before in the history of mankind.
And let me just jump in real quick. The thing that's absurd, and I know it's going to come as a shock, is politics. So the politics involved here are that nobody wants to be soft on crime. No one wants to be soft on, the war against, drugs, which goes back to the 70s. Now, the rates of death have gone up, 6-10-fold from heroin at least. And if you were to look at any other policy instituted that led to this many deaths and this much suffering of families and increased crime and all of this, you'd say that's absurd. How could we keep going like that? So when you say other countries, Portugal continued to make drug selling illegal, but the use of drugs was made legal, and therefore people came and they got into treatment, and the rates of HIV plummeted, the rates of heroin use plummeted. So there are plenty of examples out there of successful programs. Switzerland, Portugal, even in this country, if you go west and look in, Oregon and the like, people have instituted policies that decriminalize the use and treat it like an illness and get people treated. So yes, it's worse in this country largely because people can't roll back a failed solution that just is killing people. I cut you off. I apologize.
It's also, I want to address the rehab situation because as Nancy and I have shared, rehab was a big joke, quite frankly. A lot of these rehabs that my son was in and out of, I lost track. My husband probably has a better idea. They were money grabbers. That's all they cared about. My son was given certain things in there. We even had a situation where he was in an after care home facility and the woman running the facility was coming on to him. I mean, the stuff that we learned and were exposed to, and some of these rehabs, I was running out of money, going broke, quite
Because
frankly.
insurance doesn't cover.
That's right. And they wanted me to, take my son to some rehab that had, 2 windows and a door in the hood. And I was like, I'm sorry. I pay a lot in insurance. You're telling me that my son doesn't get to go to a really top-notch rehab with great doctors? It's a joke, quite frankly. And that's one of the things that Nancy and I want to expose, because I believe that these rehabs need to have some sort of accountability. They need to be responsible for how they are run, what's going on there, who's working there, who's calling themselves a counselor, a doctor, a professional. I that's one of my biggest issues with how we handle addiction in this country. And guess what? It's a crapshoot, because if you're predisposed to addiction and you have the addiction gene, think about it. We have this beautiful baby and we love this baby and we raise this baby and we have no idea if that baby has the addiction gene. If it runs in my family, I don't know. So it's such a crapshoot. And then you think you're sending your child away for help, and you're not. You're sending them to get high school. That's what it's bad.
Yeah.
Yeah.
I'm sorry.
Oh, yeah. And I'll speak on that because when I had gotten out of rehab, I went to a sober living in Orange County. And, my mom and we went down there. We met with the woman who was running the place. And, this is our manager and da-da-da. And then when I moved in there, the manager was actually just another patient like me. And none of the girls were really sober in there. Oh. So then, therefore, I was like, well, I'm not going to keep going to meetings. I'm not going to, so I relapsed there. But then later on, I did go to an actual great sober living in West Covina. And I, not the nicest place in the world, but it was what I needed at that time. And they were like, we're going to give you 2 weeks to come up with the money. And I was able to do that. But it was from word of mouth. It was from someone in the program that was like, you can go to this place. They're legit. Like, so there needs to be checks and balances on this stuff. 1000%. Yeah.
Well, 40% of the people that work in any rehab have absolutely no medical training whatsoever. And they're giving medicines that they don't know how to give. They don't know what side effects. So when you're always hearing about, they found somebody dead in the rehab, and then the people aren't smart enough to call when they see someone passes out, and that's not good medical training. And you hear about so many people dying in rehab. Also, I experienced it a lot of times. Some of the best ones, some of the worst ones. They look at you and they say, "Well, how much can I charge you?" Your insurance does not cover it. But very often, the only job you can get when you leave rehab is to go work in a rehab, and that's not a really good business model. Doesn't work really well, and a lot of people. I have friends whose children have actually died by the technician working in the rehab giving them drugs and them dying in the rehab. So it's not a good thing.
I wanted to ask Megan just to share a little bit more of your story. Just at your worst, what was it like, and what do you really think was the thing that made you be able to turn your life around?
So at my worst, I had gotten fired from my radio position where I had started up in San Francisco. I was a little bit of a thief, and I lost everything, like my job, my house. I was like staying in the car, staying on friends' couches, and it's important to know, like, as an addict, like, I'm an alcoholic. I'm a meth addict. I'm a coke addict. I'm a heroin addict. If you put a drug in front of me, I'm going to do it. I don't really care what it is. And so I had tried various times to get sober, and like, you talk about relapse, and it's like so many of us, we relapse. And for me, what it was actually, it was a really good friend of mine at that Orange County Sober Living. He was at another one nearby. And so we were hanging out a lot, and we were sober at first, and then we relapsed together. And it was not too long after that I had gotten a phone call from his dad early one morning that they had found him in the backyard of the Sober Living, and he had overdosed. And at that point I had gotten out of that Sober Living. But that was the moment that like really gutted me, and I was like, I'm contributing to someone's life in this way. And I can't do this anymore. Like, I'm going to die next, or I'm going to go to prison. Something bad is going to happen to me. And so that was what really helped me turn my life around. I actually 5150'd myself New Year's Eve, 2015 going into 2016. So that was a great new year for me. And I just needed to physically be on a hold because I'm such a fiend that like I needed to physically not be able to go and buy heroin. That's how bad it is, you guys. Like, it's like a demon is inside of you, and you have absolutely no control over what you're doing. It's like, the example I like to give is take your phone and put it in the drawer for the day and go about your day. And then how many times do you think to go grab your phone? Yeah. That's what it's like to be a drug addict. Yeah. Every second. Like, my whole day would be, when do I get to go and use, I have this much at home. Just like always doing like chemistry in your head, trying to figure out how much you have to go until you have to pick up again. And so for me, after my friend's passing, that was when I really hit like my rock bottom. But rock bottoms look different, and for some people, it doesn't have to be losing a friend. For some people, it really is, I would say, a spiritual bottom. So it's just when you feel so spiritually bankrupt and you just are that low to where you surrender and you just go, I don't know what I'm doing anymore. So for me, like that was really what it was. And I'm just very grateful that when I went in and I did the Sober Living this time, and I stayed there for the 9 months, and I did all of the meetings, and I worked the program, and I just continue to do the same things that I do today, the same things I did then. And I just keep my recovery as my number one thing. So, yeah.
You said something which just rang for me, which is, you said you did the chemistry in your head. And what people need to know is that what happens to the brain is it gets entrained the more times you go through that turnstile, the more times you use the drug, the more it becomes a necessary habit that you cannot break. So, but the other thing is to let you know, and you're, I think, living proof of this, is that one of the big risk factors for drug addiction is people who can just enjoy life in a way that is miraculous, is wonderful. You know, there's a reason 1 in 5 people in this country are addicted, because those are the people who can have such a good time when the drugs aren't involved, and then they get hooked in the drugs. So these are not people who are, throwaway people. These are the people who allow us to enjoy things, the poets, the, artists and the like. But I do want to just say one thing hopeful, which is that the most hopeful discussion I've had recently was on the car ride over here. And I was talking to Dr. Dunn, and the need we have for the problems with rehab. Yes, people who are filling the gaps have no idea what they're doing, but there aren't good treatments. And what was so inspiring was hearing Kelly talk about all of the different ideas she has and all of the opportunities. So will you just touch on that? Because
What's in the pipeline for us? I
was
think
so
everyone really
inspired.
wants to know. Yeah.
Well, that's very kind of you. Thank you. I think that there's a lot of new transformation happening. So there's kind of a re-understanding of how we might approach addiction treatment, understanding that the medications that we have. So just for context, in 1965, there was a theory put forth for depression as well as addiction, how to treat both of those conditions. And since that period of time, we have identified 90 different medications that we can use to treat depression. We have 4 for opioid use disorder, which is a highly fatal condition. So I think there's a recognition now that we've underinvested in addiction treatments, and there's some medications that are being developed that are a very new way of thinking. So there's repurposing of sleep medications like Balsamra, which is a medication that's been approved for sleep, but seems to really help with that drive that people have, so that it interrupts that. Because even when people stop using, if we can get you through the withdrawal of a drug, you still think about it a lot, right? You have this drive to continue to use it, and we need to interrupt that. And Balsamra seems to do that. There's things like,
I just have to in truth in advertising, let you know that it's Dr. Dunn who's led those experiments, and they were funded by the Nancy Davis
Yes.
Cure Addiction Now.
Yes.
So this is in evolution as
Yes.
you hear. Yeah.
And for fairness to Balsamra, it's not approved for this indication. We're just testing it. But also there's things like the GLP-1 agonist. So Ozempic seems to work really well to help people, and they're working in a very different way. So it's interrupting the drive for use in a way that our current medications don't do. And so it's uncovering these new pathways that we might be able to study that would be it would complement the existing treatments that we have, because we're not investing in it. And that, to go back to Cure Addiction Now, I think I wasn't aware of the underinvestment until Nancy made me aware of this. Other fields of medicine have tremendous opportunity for people. So when people come in for treatment for opioid use, for instance, if the medication doesn't work, we don't have many alternatives for them. It's really, we're kind of addressing it in one way. And if you're not responding well to it, that's, we don't have anything else. Whereas with depression, if it doesn't work, we have other meds that we go to, right? We just keep cycling through other meds until we find the one that works. But we don't have those. We don't have that arsenal of medications for addiction, so we can't do that. But that's what this is, right? This is seeding those opportunities. So there's lots of, and the National Institute on Drug Abuse has 80 different medications in their pipeline right now that they need help developing. So there's growth potential there.
You were telling me this week about a vaccine.
Yes, we're really excited. There's a vaccine being developed that would be for opiate use. So if you're an opiate addict, you'd have this vaccine, and the rest of your life you would never crave an opiate, which would be amazing. And if you have the opiate anyway, it will be blocked in your system. So that would be the end of that. It doesn't stop you from taking another drug. And you were saying you take anything, but a lot of times I think the biggest portion of people who have addictions are to opiates somehow. So I think it'll be a great thing. Another thing we want to develop with the same people is to create a vaccine that when you're born, if you happen to have a propensity to becoming an addict, that you could have a vaccine when you're getting all of your other childhood vaccines. Wouldn't it be great if you could give every one of those kids a vaccine, and the rest of their life they would not have to go down this rabbit hole and be addicted, and for you as a parent to always have to worry? And I think that would be the great miracle that we would like to make happen.
Is there someone who's you can always see who's going to be more likely to have this propensity towards addiction, or is it just if there's a family history?
I think as a parent, you can see how your children are all just a little bit different. They all have a different way about them, how they deal with things, how emotional they are, different things like that. And I could, my Jason, my son, he was terrified to have a drug. He really was. He'd been in a movie with Chris Farley when he was younger, and Chris died, and Jason was 12 years old. And Jason thus began this crazy journey at school. He did all these charity events that were anti-drug, and I knew that he would never use drugs because he was so against it. And he was raising money. He got his programs at school on TV, and it was pretty amazing. And you just knew that it had hurt him so much by losing a really good friend. And then at 21, he had a back injury, and his friend came to him, and he said, "Well, if you smoke opium, your back will feel better." And he did, which, it's better that he waited till 21 to have his first drug because your brain's at least developed. But thus began about a 12-year journey of him being an addict off and on. And it was very hard for him to detox and truly stay sober. He had these terrible cravings, and you could just see like his face would light up. And as a parent, you want to be able to take your child to the doctor and have the doctor say, "Okay, your child's been diagnosed with addiction. Let's give you this medicine." Well, there was no such thing. There was no medicine. There's rehabs. Each rehab's different, and you might go to the same rehab twice, but it's not going to look the same any 2 times that you go because there's going to be very different people there because they don't last very long. And you suffer for your child because you want to save their life. It's terrifying. I never went through such a horrible thing. There's these late nights when the phone rings. You're so terrified that you're going to get that call, and you're praying to God it's not from the morgue. Sometimes it's from jail. Sometimes it's from a hospital, an emergency room, or a friend. And you just pray to God that your child didn't die. One day, unfortunately, I got that call, and it was exactly 5 years ago. And my husband called me. I was on a trip with Isabella, and that was the worst phone call of my entire life. And you, as a parent, you feel like you're such a bad parent. You're like, why could I not have stopped this? How come I couldn't save my son? I know he had a problem. And at that point, I thought he was doing really well. I thought he was doing well. I'd been sober for 9 months. And all of a sudden, that phone call was the worst thing that ever happened in my life. And I'm like, this can't happen. This just can't be. This is impossible. And I had to deal with it. And I was like, oh my God, what do you do? I'm one of many parents who gets that call, and we have to have tools for parents to be able to be good parents. And no parent should feel like a bad parent because we have obviously not spent any money, time, energy over the last 25 years creating medications and things to help us be able to help our own child because we are ill-equipped. We don't know what to do.
I can tell you that my sister, when she lost her son to fentanyl, just said to me, she came to me and she said, "I just can't go to parties. I can't talk to anybody because everybody asks how how are the kids doing? And I just can't face it because I feel so guilty." And I said, "I know who you have to talk to." And she called Nancy, and that started her down the road of recovery. So, but I'm curious, we talk about people at risk. Isabella, you are one of these kids in the family who was affected by the death of your brother. What's it like from your standpoint?
Yeah, I mean, I think addiction affects everyone in the family. I was 15 years old when Jason passed away. And I knew from a young age, I was educated by my whole family about what addiction was. And it was never something that they wanted to hide from us. They wanted us to learn about it, know that he was sick at the time, especially since we were so young. And there were moments where as you got older, you saw how everyone was affected and you learned about other people who had overdosed. And sometimes I would think what if this would happen to Jason? And there were moments where I was definitely really scared. And it was interesting because he was sober for 9 months, and that was in those 9 months, there was never a thought in my mind, like previous years, that he would not be okay. And I think that's when it becomes so unexpected. So many people do relapse, and for him, he was doing great and he was happy and he was working. And so it just takes one little thing, like a bad day, to throw someone off. And he did take drugs the week he passed away. But I think it's also about educating other people, friends like mine, because I know my mom might be able to connect with other mothers who have experienced this. I think as a sibling, we don't talk about it a lot. Other siblings who have lost a sibling from addiction or even mental health. And I think that was a lot harder for me, is being able to find people who had similar experiences. And I also remember when he did pass away, having friends mention and hear about stories about how they wouldn't tell their parents about my brother's passing or the reason why he passed. And it was very interesting because if someone had passed away from any other disease, they would be able to share it with their parents. But there's this idea that somehow him doing drugs made my whole family look bad, especially to other parents who were sending their kids to our house. So I think, yeah, you didn't know about that?
No.
But I think in that moment, I really wanted everyone my age and their parents to be able to talk about it with other kids and not have the stigma and not be ashamed because, like everyone said, it is a disease. So, yeah.
How do you think it's really shaped your life then as you move forward into young adulthood now? And you're away at college and what you see at college, and I guess maybe how you witness to others in some regards.
Well, I definitely think it's made me a lot stronger. I think I just was able to connect with my family about grief in general, and then what addiction meant. And I think it took me a while to realize like what I can do to help his legacy and make sure that he's remembered every day, because that was my biggest issue, is never wanting to, well, I would never forget him, but also going into college, not having people knew who he was a really hard thing to swallow, especially since you're making new friends and, you know, they might not know your story or your history. And then it's also impacting others. I think college is a big environment where people experiment a lot. And I remember I have older cousins and, you know, even with my parents, like there was a time where sometimes people could experiment and try different things. But now is a time where you can't do that.
No.
You know, you're gambling with your life, literally. And, and I think that in high school I saw it a lot, of going to parties and people overdosing and needing to call the ambulance. And, you know, the fact that that was happening at least to one person at every high school
party
was not something that should be normal or accepted in any way. And then I think going to college, just educating people on the fact that if you are experimenting with these drugs, how do you know fentanyl isn't everything? And to be aware of how this affects people.
Nancy.
I do want to say that I feel Jason here in the room,
Yeah.
especially through you, because Nancy was there when Jason sort of came and got a bunch of doctors in the room and said, what the heck are you guys doing? I mean, you know, when is the cure going to come, and challenged us. And just, you know, he was the first person to have these meetings with the clinicians and sort of vet us to see if we were up to his standards.
He
And
was
now-
a bigger than life presence.
Yes.
You know, you could not, just like Nancy, you could not ignore Jason when he walked into a room, you know?
He was this, you know, go big or go home person. And he wanted this charity so badly. He said, Mom, I'm going to too many funerals. Your friends, you don't go to their funerals. Why at my age? I'm 30. Why am I going to funerals of friends of mine? he knew lots of people that were addicts. It wasn't okay. And it was just so sad and so final. That's why he really wanted to start this charity. It was so important to him. So right now I feel really excited in the fact that I do feel Jason's presence all the time. It's crazy, but I feel that he would want this to happen. He said, "Mom, it's the scientific thing. It's about the science. It's not about the spiritual. There's got to be both. You've got to have everything wrapped into one, and we've got to help everybody." He was failing, and he loved life. He had such a spirit. He was so talented. He was fun. He was funny. He could write. He could sing. He could play the piano. He could dance. He could do everything, and he had such big dreams. And to think that he didn't get to live his dreams is sad. I mean, every life is precious. Everybody's life is so important. Everyone should be empowered to be able to live whatever they want in their life. At least try it. And it's so sad that, you have this propensity to becoming an addict and you try your first drug. Doesn't mean you're a drug addict even, but a lot of kids are dying. They're dying the first time they try something. And the fentanyl crisis is one thing, but kids can't afford to have the luxury of trying a drug anymore. It's different in my age. I mean, you weren't going to die from it. It wasn't that it was the right thing to do, but today there's a really good chance if you buy something that's not in the drugstore, there's a good chance that I think it's 90% chance that it's going to be laced with fentanyl. Fentanyl is the equivalent of you having 50 to 100 shots of heroin. Whose body can withstand that? Nobody's.
No. Is there something that you guys like? Do you have a goal for this next 5 years? I mean, is it different drugs? Is it different protocols? I mean, what is the hope for the next 5 years?
We're going to find a cure for this horrible disease. We're going to save a lot of lives. We're going to do it in a science-based way. We're funding something that should have been funded forever. I don't know why it was not funded, but we're going to the laboratory and we are going to find we're going to get FDA approval on a lot of drugs, and we have to. It's not a question of it. We're gonna have to work as fast as we can. We're only gonna fund research studies that have quick results, and we don't want to fund something that's gonna take forever, because that's not okay. If you looked at one person's dying every 5 minutes of an overdose, another I don't know, one person's overdosing every minute, and then you might not die from those overdoses, but you have terrible, brain damage and different things that are happening from having these overdoses, from having a lack of oxygen to your brain. It's the worst disease in our country. It's the leading cause of death for people 48 years old and younger. We have to stop ignoring this and stop shaming people. Anybody that has a disease does not need to be shamed. They need to be loved. They need to be embraced, and they need to be helped immediately. And we are doing everything we can. We need tons of help from lots of people. We're going to do the best we can. We're having our first event tomorrow night, and I'm really excited that we are. And we're going to get the word out, and we need everybody to help us fund really important studies. And I'm so grateful that we have the brilliant doctors that we have. When I first started out, it was really hard to find any doctors that had done any research studies. It was really complicated. And I went to NIH and talked to them more thoroughly, Dr. Nora Volkow, and met Dr. Kurt Rasmussen, who couldn't be here today. And he had known where all the bones were buried. And he directed me to many of you, and there's other doctors on our team. As well, we have 10 doctors that we're funding around the country. They're simply brilliant. They haven't had the opportunity to get as much funding as they deserve to do these studies that are going to save a lot of lives. We spend more in our country every year on eczema, seborrhea, psoriasis, herpes. I mean, those are great, and you should fund them. But why have we spent nothing on this disease that is the biggest killer? It makes no sense.
Are we close to some breakthroughs at this point? Would you say something close?
I think Kelly would want to talk about breakthroughs. Yeah.
I think in the next 5 years, there's breakthroughs. I think there's ideas that are being tested now that are very novel. I mean, historically, it's difficult for us to test those studies because the process for us to do studies comes mostly from the NIH. And that's a very long, arduous process. It takes several years for grants to be funded. We need a lot of evidence for them to invest in those projects. So it's really difficult to get these high risk, high reward studies off the ground. But funds provided by CAN are really helpful for that, because we can test the things that we think scientifically will work that nobody has really given us an opportunity to test. And there's things like psychedelics, right? There's lots of new transformative opportunities that if we can just get the data to show that they work, then we can work with industry and we can work with NIH and we can more rapidly move these things to market. I do also think that there is an acknowledgement, finally, it's starting to turn, that we are underinvested in this area and that what we have is not, probably, in my opinion, is not enough, that we need to complement it and identify new opportunities. So there are several things in the pipeline that are just brand new approaches, which I think is what we need. We can't keep doing things the same way. We have to do things totally differently.
I just also want to say that Nancy and I have also discussed what is also incredibly important is raising awareness, helping families that have this going on, that they have proper tools, they have proper support, that we all, I think it's going to take all of us not treating it like it's a secret, not treating it like it's something to be ashamed of. It's actually something that needs to be brought out in the open. It needs to have light shed on it to say, hey, don't be ashamed. You're sick or they're sick, and this is an issue that needs to be addressed on a global level. And Nancy and I have talked about taking it to the government and talking about how can we be creative, how can we be intentional about creating proper programs, giving families proper support. I mean, my husband and I had to have my son 150 like 3 times. And they'd ask my son, oh, are you going to hurt yourself or anybody else? Of course he's going to say no. And they would send him right back and and we had no idea what to do. And they 3 times. And look, my son ended up shooting himself. And then when they found my son, I was out of town with my family, and the disgusting way everything was handled was because my son looked just like me. He was brown hair like his mama, brown eyes. He didn't look like his blue-eyed daddy. And they treated my son like, oh, this is just another brown drug addict kid. I mean, nobody called us, the police department, nobody. We had to chase this. It was disgusting. And so Nancy and I have just discussed just not only this, but in addition to it, creating the awareness and the support that addicts need, and also their families, and how the government should be involved in taking part in that.
Can I add one?
Yeah.
Yes.
Along with awareness, I think, at least for the 5 years for Cure Addiction Now, I think we work towards bringing awareness, and also the more people get involved, hopefully having a bigger event, bringing more people in, having brands want to have their name associated with a charity about addiction, which I think we found. Which I think we found was a little difficult, is a lot of people weren't sure, because there is still a stigma, and having something connected with the word addiction is not always accepted. But I think in the next 5 years, if we get more people to understand that this is a disease, to have more sponsors, to have bigger events, then we'll be able to get the bigger funding so that we can, put it into these projects, because everything Cure Addiction Now does goes to these projects and to these doctors and to these researchers. So.
Well, and you come from a long line. I think of what your grandmother did with childhood diabetes, right? And then what your mom is doing, and now I know that you're taking, the lead on this with your mom, and it's really it's really beautiful how you've done this. Yes.
Just to add a comment, so I think in the field of depression, which I often think of as kind of our comparator field, we know that if people identify themselves as somebody who has depression, that significantly reduces stigma. And that's why I just think it's wonderful that you're willing to do that, to come out and talk about family members or yourself having this experience, because it directly reduces stigma. That's an effective campaign. And think about how much easier it might be for us to intervene as a medical program if somebody comes in right when they develop addiction, right? So they just identify that that's what they're struggling with, and they go to their doctor, and we can intervene early. like we would like to do with any other medical condition. But a lot of people feel so stigmatized that they wait and wait and wait until they've reached, we often hear about this in movies, right? You reach rock bottom before you come in. And we can help you when that happens, but it's going to take a lot more work, right? People at that point there's a lot of other things that have happened. There's legal problems or medical problems and social problems and family problems. And it just takes a lot. And we want to help people in those circumstances, but if only they felt like they could come in sooner, right? And I think being able to talk about it and openly identify yourself as somebody who's been affected by it helps them to feel like they can do that too. And then that helps them to go and speak with their providers.
I know you wanted to say something, Dr. Kaplin.
Yeah, thanks. First of all, I just have to tell you, Isabella, you don't need to go to business school. You're ready. You were saying ahead of this that you're interested in not-for-profits, but you're ready. I think that for me, what is absolutely the case is that we do need more research. Clearly, we don't have any treatments, for instance, right now that get at cravings, and cravings that maintain themselves are why people relapse. How we are not addressing this as a profession has been a difficult thing. And now I'm so inspired that we have, from the emergency rooms and from Kelly taking control of what's going on at University of Maryland. That's exciting. But what I think is really exciting is that despite what's going on and the unraveling of research in this country, at least putting it in jeopardy, we have Nancy here who is pulling together and funding the Hail Mary. She's not, going to take the incremental, let's just take a small baby step. She's going for the big, she's shooting.
Go big or go home.
Go big or go home.
Nancy.
And with the help of everybody here and the people who will see this and destigmatizing it and getting people motivated, I think that's, to me, the most exciting set of things.
Yeah. And lastly, I just want to say, as an addict, this is incredible, the work that you guys are doing, because, it's not a one size fits all for everybody, and I wish that I could have, it was just hard to get someone to help me, to put me into a rehab or sober living. I couldn't even get help with that. So to be able to go to a doctor and say, hey, can we try this? Can we try that? And you don't have any avenues, And so just because 12-step works for me and it may not work for others, I just want everybody to be okay. I just want people to have a good quality of life. I just want people to stop dying, And so, and I love what what you said of just breaking the stigma, and that's what we're doing. And we get to do this as a community and as a group. And, with this, first year of, Cure Addiction Now and this first event, and it's just going to grow and grow. And we all, get to be a part of that and stand together in that. So I'm very grateful for what all of you are doing, for, the addicts and alcoholics like myself. So, yeah.
We have some time for questions, and now's your time because you've got all the best of the best up here. So, yes. Oh, wait. We're going to get a microphone.
He wants to say one more thing.
Oh, you wanted to say?
Oh no! I mean, I think you just said it.
Dr. Herring, before we go to that too, I also want you to talk about what you're doing. About a year and a half or 2 years ago, we were talking to Dr. Kelly, and she's from Johns Hopkins at the time, and she was saying that it was so hard for people to detox off of fentanyl, and you wouldn't think most people are addicted to fentanyl, they're not knowingly, but they are. And you were talking about how people were jumping off the building, that the detox was so rough, and you didn't know what to do. So along came Dr. Herring about a year later, and you were talking about what you're doing at your ERs. He's in, where's your ER? It's in
Oakland.
In Oakland. And I think it's now 282 different hospitals in California. And the idea of setting a way for everybody to know what to do when they go to an ER. People cannot, it's a joke to think that everyone can afford to go to rehab because it is definitely not covered by insurance. It's very expensive. But the first place that people would go is to an emergency room. And you had a very different way of dealing with patients there. And you were talking about how you gave the 2 doses of ketamine, and that was able to give that person who for like a $17 visit. And I know, tell your story because I think it's fascinating.
Well, I think it really sort of segues really closely to what you were saying, where I don't think people quite realize how difficult it is just to, when you're seeking help, to not end up in some nightmare landscape of predatory treatment centers or government-funded agencies that just don't have the time, the space, the staff to help you. So in what we know, right, is this is a medical disease that has effective treatments. And those treatments are getting better and better and more broad every year. But they're not getting to people. So what we did in Oakland, I mean, it sounds a little crazy, but basically I just partnered with a nonprofit. I got a bunch of local kids from the community, nice, personal people, and I gave them like 5 telephones and said, you know, when that phone rings, answer. And then I recruited a bunch of doctors to stand behind them. We got the word out in the community so that if anyone who was, had themselves or their friend could just call, and that within moments, like within minutes, they could be talking to a physician who was expert in using whatever tools there were. For some people, that might be coming to the ER and using ketamine to treat their hyperalgesia and promote response to the opioid. For someone else, it might be looking at their sleep and co-occurring depression, all these different things. Without any red tape, without asking them about their insurance, without asking them about their citizenship or their county of residency, or making them do a 2-hour intake, or all this crazy stuff that currently is the standard experience. So our big goal is simply to make that available, right? So that everyone in this room should have a number, should have a place that they can refer themselves or their friend, where they call up in that same day that they're given access and counsel on how to use the most modern and effective medical treatments. Like, that's our big goal.
And you talk about ketamine, but of course, a lot of us heard about it for the first time when they heard about Matthew Perry and how he overdosed on it. But it is a very useful tool when used properly.
Absolutely. I think medicine is powerful, right? Medicine is powerful, and it needs to be done with people who have a sense of responsibility to do the right thing for people. And they can be it. That is the burden of being a physician. And so there are goods and bads to almost every medication we use. And ketamine is certainly powerful. If you use it right, it can be really used for positive change in people's lives. Absolutely.
Just to put it in perspective, the levels for depression that we use ketamine at is 100 to 200. His levels were 3,000. And so it was just a different kind of thing.
Enablers were. And that's part of the story, too. Right. We didn't even really touch on the people that you're surrounded by who are enabling you in spite of all the best efforts of those who truly love you. I know you wanted to say something, Isabella.
Yeah, I just had a question. We've talked a lot about different kinds of addictions, but can anyone speak on nicotine? And I think
big nicotine addict.
That's
all I can say.
I think so many people do have family members who deal with opioid addictions and alcoholism, but I know a lot of teenagers and young adults are very addicted to nicotine and vaping and cigarettes, and it's not a fast death like we see with fentanyl, but it is a long-lasting, it has serious long-lasting effects later on.
So I actually think that there's similarities between nicotine and fentanyl in the sense that both of them are things that people tend to administer multiple times a day, right? So it's not common that if you smoke cigarettes, you only have one a day. You have them all throughout the day. So you have a lot of small exposures. And as Dr. Kaplin mentioned, the more exposure that you have, the more it trains that drive to continue to use it. So in that regard, it's actually really powerful. And we know that it co-occurs with a lot of other substances. So if you use fentanyl or if you use alcohol and you smoke cigarettes or if you use other forms of nicotine, it actually enhances the effects of those. And it has a small interaction effect, so it increases the likelihood you continue to use it. It's incredibly difficult for people to stop using. We do have medications available for it that are we have more medications for nicotine than we do for opioids that work very well for people, but they have the opportunity and they can go right to their doctors and request it, right? So unlike other unlike opioid use where it's difficult to go to your doctor and say, can you give me a treatment for opioids? For nicotine, you can go and they ask you as part of your standard intake generally, and then they can prescribe right then multiple different forms of medication.
Like a patch. Can we get a patch for it? I think we all think of that for the nicotine. Wouldn't that be amazing if there was a patch that was so easily accessible?
I think one of the other problems, really quickly, is that the mindset of our young generation, of too many of them, and even I'm going to say even a little older than Isabella and Max's generation, is this idea of how cool drugs are. Like, I went out to sushi the other night with my family, and there was this whole table of young adults talking about how cool this party they went to was, because they had like free Coke, and they had this great acid bomb thing, and I was this close, so close to getting up and saying, I'm sorry, are you actually, let me tell you about my son, who's dead now, and how this conversation is disgusting and it's irresponsible. I didn't, because my husband warned me that I might disrupt the whole restaurant. But I just think things like that, like we're not making that shameful. We're making, the disease shameful. And it's just such a big issue. And Nancy and I have also talked about really quickly, like, my son was a soccer player and then he got injured and the team doctors put him on Oxy. Hello. So there's that whole issue that, the irresponsibility of the adults in the room not doing the right thing. So.
One more thing. I know a lot of parents think it's kind of cool to smoke pot with their kids. If you start smoking pot when you're less than 21 years old, you will probably have a psychosis the rest of your life that you can never get over. So to use pot before 21 and to act like it's cool, and any parent that says it's cool, oh, I smoke some pot with my kids, I mean, you have to be out of your mind. Yeah. You are promoting the worst thing and the worst role model to look up to. It's just wrong on every possible level. I just wanted to say that.
You want to open it up for questions now? Okay. I was just asking you for permission. That's all. I wanted to see, because you have all the experts here and people with all the real life experience. So, yes.
So my question is to the doctors. My understanding is that of every 100 addicts, 89 of them, I'm talking about opioid addicts, will remain addicts their whole life. And of the other 11%, 7% will go on and off, they'll relapse. Why are there other 4 that can stop and never do it again? And how does that factor into finding a cure with those 4 people that will never do it again? They just can stop.
Do you want to lead, or?
I might just jump in just to frame that question. Just I often like talking about physicians who are addicted, right? So if you're a physician, and it's really tracks. So doctors that are around, they're actually administering opioids. There's one thing for me to sit at the computer and order, Dilaudid or some opioid, and the nurse gives it. It's another thing to have it in your pocket and to put it into the IV and to push it and see the experience. You kind of vicariously get pulled in. So those physicians or nurses are actually quite high risk to becoming addicted. Now, that person who's gone through high school, they've gone through college, they've gone through medical school, their chances of being abstinent, meaning not using, back at work, are probably 90%. So the reverse, right? And so it's just to remember that number is that idea that 90%, will not stop to use. There's so many other things going on. Whereas you take someone who at 12 they're smoking. At 14, they have the first time they drink enough to black out. By 15, they're snorting oxy. And 16, they're using methamphetamine. That person has this accumulation of disease and changes in their brain that are going to take decades to unwind. And that person's going to need to be protected for decades, which maybe you guys can speak to a little bit.
So I'll let my learned colleague finish to be the anchor here at the end. But one thing that you're talking about, of course, is illustrating is how one size does not fit all. Different people respond differently. And there is a certain temperament that people have. Some people are really focused on the now, what have you done for me lately? How do I feel right now? As opposed to, the future and the past. So there's a temperament. Then there's also, we know that people who are of Irish descent tend to have more aldehyde dehydrogenase, so they can break down alcohol, which means that they can take higher and higher levels. That's in contrast to people who are Asian who have lower levels, and so they get toxic buildups of some of the product. So that there's a genetics that we know of that plays a role. And then finally, it is also that craving. It's needing to get after the craving. It's getting after the fact that the brain has been rewired to experience, everything that is potentially addicting. And so that rewiring, we need to be able to get into that wiring and change that wiring. And that's because nobody is doing it. And that's why Nancy's funding the research and why Kelly will tell us what she's doing at the University of Maryland related to, how difficult it is with the heterogeneity of responses.
Yeah, so I worked in the field of opioid use for about 20 years, and that's a big question for me too. How are some people resilient and other people aren't? And I think I don't have a good answer for you. Scientifically, we don't have firm answers, but I think it's an interaction of the environment and the person. And we do know now that people have different responses, right? So if I could probably ask the audience if some people will take an opioid for the first time and won't really feel much of an effect, and other people will take it for the first time and they'll feel nauseous, and some people will take it for the first time and they'll feel energetic, so it almost feels like a cocaine-like effect. And those people are probably more likely to continue to try it, right? But the people that felt nauseous are the ones that'll say, I don't know why you would continue to do this, right? When I use it, I feel sick. I don't know why you would keep using it. But it's because the people that keep using it didn't feel sick. They felt different. And that's what we see in the people that come into our clinics. They often say, I used opioids because it helped me get my home, my housework done. And it gave me the energy to take care of my kids. And that's not what you think of when you think of opioids. And so those people, if they get exposed to opioids through a prescription or maybe at a party, they're probably going to be higher risk for going on to use it. And we don't understand why that's the case, but it's an interaction. If they never come in contact with opioids, then they won't. They're higher risk, but they never use it. And so it seems to be this interaction effect. And there's a lot of interest in us in learning, because we want people who are in pain to have access to medications. And if you've had somebody who's had pain, you don't want them to be scared to treat their pain. We just want to do it safely. And so that's kind of talking about the breakthroughs. That's a lot of the work that we're doing at the moment, is trying to figure out in advance, what exactly can we ask you in a doctor's office to understand if you're higher risk, so that we can tailor your treatment or help you understand your risk profile and prevent that interaction from occurring.
Do we have some other questions? Yes, back here. And then we'll get to you up here as front. We'll get the microphones to you. Go ahead.
Okay. Hi. So I'm a student. I'm studying social work, and I'm just really happy that this organization exists. I'm really appreciative of the Narcan, and so my question is for Megan, I think. How do I know as a bystander when it's time to intervene on someone who might be overdosing?
I mean, I feel like you're usually going to have a good sense of it. And here's the great news with Narcan is that you can administer it to anybody, like even a pregnant woman, and it's not going to do any harm. So therefore, through administering it, if you give 2 doses back to back and they aren't revived, you're like, it's kind of going to give you a better idea that, okay, you can rule out that it was opiates, caused by opiates. But obviously in the meantime, you're calling 911, you're getting the paramedics on the way. And, they're going to have really pinned pupils, shallow breathing, clammy, sweaty, that kind of thing. So yeah, but I just love the fact that you can give Narcan and it can't hurt anybody, which is great. Yeah. Mm-hmm.
Okay.
Good description from a standpoint. Exactly.
Excellent.
You guys didn't have to jump in at all.
No, I was waiting.
And everybody has Narcan under their seat, so you should all take the Narcan. You should keep it with you wherever you go, even in your glove compartment. If you have a backpack, a purse, or something, there's no reason to not have it with you.
One of the things about Narcan I just have to bring up is it is one of the few attempts that the combined public and medical health system has done to make something broadly available. It's just, so it's just interesting as a reversal, but also it's the one example of a strategy actually trying to push out so that everyone has access to it. And it's kind of what we need to do for all of these other treatments. They need to be just as accessible as the naloxone here sitting underneath your chairs.
Go ahead.
Thank you. My question is a two-parter. if That's okay. I'm really glad that Isabella brought up the nicotine because I have countless friends that are just, it's like every day, all day. And one of my friends actually really wants to stop and he just can't. So my first part of my question is why, for the medicine, why would it only affect an opioid versus if someone's addicted to weed or nicotine? And, you know, for example, my grandpa tried smoking and never smoked again, right? Is that part of like the addiction gene? How does that medicine like stop someone from doing opioid and not a cigarette or weed or alcohol?
So that's a really great question. So the drugs that produce addiction all in some way work on a certain system in the brain called the dopamine system, but they also work in other areas. And so nicotine works in a different area than opioids. So the medications that we have to treat opioids are specific to that opioid system and not to the nicotine system, and then vice versa, right? And so we know that some of the medications that treat nicotine don't interact with the opioid system. So we would need, if somebody had both, we would want to layer both of those medications together. There are some more medications now that for a long time we've treated these illnesses as different silos. So we developed medications for nicotine and then opioids and then alcohol. But we're recognizing that a lot of these disorders have very similar components, right? They all have craving as part of them. Most of them have a withdrawal syndrome as part of them, and those symptoms are very similar. And so that's kind of the transformation. People are starting to think more, what's the commonalities and what can we use to treat this kind of commonality across the substances versus treating them as independent. And so the GLP-1s, I think, are a great example, the Ozempics, and they came about as an accident because people were using it and then discovered that they didn't feel like they needed to drink. And that's how we discovered one of the anti-smoking medications as well. People were taking it for depression and found that when they took it, they also stop smoking. And so, we often find these by accident, but then we can develop them specifically for that purpose.
Very interesting. Second part, for as far as the addiction gene, right? I swore off opioids and all those like hard drugs because of my brother, and I wanted to kind of honor his legacy. But if I was able to, if I was to try weed and I, was able to stop completely, but one of my good friends who has no other drug users in his family, why would he be unable to stop? But I do, or I am able to stop while I have the gene in my family. It's kind of an objective question. If you can't answer it, it's okay.
We probably all have a different answer for it, but if you wouldn't mind, I'll jump in first. I think, again, it's an interaction. People experience drugs differently. So some people, part of it is, maybe you've used in a different way and he has more physical symptoms. And so the product is kind of relieving some of that withdrawal experience that he might have. People have different levels of trauma or something that they're using the product for, right? And so it depends. Everyone has their own unique experience. And I think maybe that's a good take home from this is that your experience with something doesn't define what somebody else's experience was. And so if it was easy for you, it doesn't mean that it's easy for other people. Their experience is very different. The genes probably contribute some of it, but it's not all of it, right? So you can have a gene or a physical experience that is, very strong, and still you have other things that help you to not use them. We don't know exactly what those are yet, but that's what we're trying to find out. So it's an interaction between having the ability, the experience, and then having the product and the other things that are going on in your life at the time. And I'll just quickly say that, people, at different points in their life will use, right? So we'll have people that use heroin when they're younger and then they are in recovery for a long time and then they go back and use it later as an adult and they say, oh, it's not for me. And they're different. They've got different experiences now and they can control in a different way. And so there's just a lot of kind of interactive effects there.
So just to follow up on one thing that you're getting at and that Kelly mentioned is that it does depend on the state that you're in as well as what your predispositions are. So people will commonly self-medicate when they have depression and anxiety, for instance. And I mean, one of my patients says, if you're not anxious these days, you don't know what's going on. I mean, you guys have just been through COVID, particularly younger people have been dramatically affected. And, you know, the problem, unfortunately, is that self-medicating with many of these things just makes it worse. So, for instance, initially it feels good to drink alcohol, that it'll lift your spirits, but it actually makes the depression worse. So, self-medicating turns out to not be effective. But there are also, just as a public service, I have to just mention that if, you know, marijuana is free in many places, meaning not free, but you can get access to it. And that's great for many people. But if you have bipolar disorder in your family or in yourself or psychosis, you're at significant risk, as Nancy sort of suggested, particularly if there's psychosis in the family, of developing psychosis when you wouldn't have developed it had you not started using heavily. So, you know, it's not one size fits all. And you do need to know the context that people are in as well in terms of how you're going to help them. But it's good that you said you're not using drugs because your mom would kill you, right? I mean,
100%.
I'm not. Thank you very much.
We had some other questions in this area.
Hi, my name is Lauren. Thank you so much. I'm just so happy to learn about your organization. I have a statement, then a question. I've been in this field in addiction for 18 years, and I started this field working for addiction psychiatrists here in Los Angeles. And they had their private practice, and they also worked for some of these treatment centers. And the reason I stuck in this field and decided to, you know, start my own company was because I saw families getting taken advantage of from these treatment centers, and it just disgusted me. And you know, I also heard them say, well, now I have to take out a third mortgage in my house or go into the college fund to pay. So anyway, I just wanted to say that I totally get what you were talking about. I have seen it all in the past 18 years, from body brokers to doctors that just will write that Adderall prescription, give you as much Klonopin as you want, to, you know, treatment centers gouging you, and then to some very wonderful people. So I don't want to discount those people. But one of the things I do is help families navigate this whole mess, from getting into a 5150 to getting a mental health conservatorship to getting into that sober living that does have ethics and so on. So anyway, what I wanted to ask was, how do you plan on, I guess, advertising about your organization and to get to end the stigma? Because it's just, families are just, they're too ashamed. They're so ashamed, and they're hurting so much, and they need so many tools, but they're very ashamed. And so I wanted to know some of the ways you're thinking of getting the message out there and what we can all do to help promote that.
I completely agree with you, and I've witnessed all this, and it's really hard. A lot of people are very embarrassed that this runs in their family. There's a lot of people who call me in the middle of the night on the weekend, and I help their child or whoever get into rehab, sometimes get out of jail. I mean, there's everything that happens. And then when you go to talk to them a little later to see if they want to get involved with a charity, they don't have a problem anymore. They're afraid to have a problem. There's a lot of neglect about it. And I think we have to do a huge campaign. I don't know exactly how to do it, but I'd love you to help us. And we would love to figure a way to take the stigma away, because that's a really huge part of this whole problem. From telling somebody, you know, I have multiple sclerosis. If I told somebody today that I was just diagnosed with MS, I'm sure my friends would say, oh my gosh, let me take you for your MRI. Let me take you to the appointment. Send me flowers or something like that. But if I called the same person and I said, I'm a drug addict, you know what they would say to me? They'd cut the phone call very short, and they'd say, go get help and call me when you're better. So they're pushing me away. They're making me feel really bad about myself. They're not embracing me for my disease. They would embrace me if I had cancer, if I had MS, if I had diabetes, but they would not embrace me if I was a drug addict. So this is a huge problem. We have to stop doing this. We have some songs that are coming out, sort of co-written with Cindy Horn here too. And there's a great line in one of the songs, you're not a bad person, you just have a bad disease. Let's change the shaming for empathy. And we're trying to get this song out in a big way. And there's some things we're trying to do to educate the public in a positive way, because that is the truth of this disease. And, when I got diagnosed with MS, I was terrified. I was told I'd never walk again. And life as I knew it was over. I didn't know what to do. If I was told that from my friends, because I'm an addict and you don't like me, you don't want to be my friend, you don't want to sit near me, you don't want to be near me. Doctors do not want you to come sit in their office because it's bad optics for their business. You feel very ashamed, and it's awful. We have to do everything we can, and I don't know how to get there, but I could use all the help in the world.
Interestingly, does anybody know where the term addict comes from? It's from the Roman name for slave. So really, addicts are slaves to the drugs. We should be setting them free, not incarcerating them so just to think about that.
Can I just add another comment related to stigma? So I think in working with people who have addiction for years now, I've come to understand that they are among the strongest people that I've met, because think of the amount of daily suffering that they experience, pain from withdrawal, they're ostracized from their families and their social networks, and they incur medical problems and legal, right? They manage a lot of this on their own, and they continue every day to get up and to continue to fight. They go to treatments, they try to get better, right? And the amount of resilience. I mean, think of people that experience an overdose and how traumatic it's a near-death experience, how traumatic that is, and then to continue to experience that. And I just think in terms of thinking about stigma, right? Sometimes I think there's the longstanding belief is that maybe it's a moral thing, right? People are weak if they have addiction. But in fact, I think that they're actually incredibly strong to be able to experience that and to continue to push forward. And I think maybe something like that, kind of framing it that way and thinking about it from that perspective, would help with stigma as well.
Nancy and I also talked about a podcast. We're trying to get there. We've gone in back and forth about it, but I think that we have to use our platforms. We're all on social media, and we have to use our platforms. And that sometimes that seems scary, because it's like, oh my God, am I going to talk about this? What are people going to think? What are they going to say? How's that going to change their perspective on me? But if you're advocating for taking the stigma away and the shame, and you're saying, hey, I don't know one person who doesn't have someone they love that doesn't have this disease. If we treat it that way, like Nancy was saying, I think it starts with one person, right? It starts with one thing, and it grows, it flames up like a big forest fire,
Yeah, I just also want to say that I think less than 0.1% of people believe that addiction, alcoholism, is a disease. Even me sometimes, I can't wrap myself around that theory. So explaining how this is a disease would maybe really help the general public.
Yeah, people do not want to admit it's a disease.
Yeah.
It's a choice.
It's not, but it
even
is
my mother today was like, your sister has a mental health problem. It's not like she can't help it. It's not like she's an addict or an alcoholic where she can help it. So that's my 80-something-year-old mother. So I don't know if we're going to change that generation, but we have hope.
Yeah, I mean, I think doctors are very good at making things boring, right? And there's just this role so historically, the vast majority of any kind of treatment has happened without doctors. It's really been primarily in this world of behavioral health treatment and this sort of idea of just using science, thinking about this as a biomedical disease or biological machines. You're a mammal, you're a rat or a rabbit or a human being, you're exposed to a substance for an amount of time, your brain changes, and then we have tools to help you combat those changes over time. Like it's just incredibly dry. And pushing that into just common medical care at your doctor's office, at your ER, that I actually think is incredibly and powerfully destigmatizing. And that's something that really, if the potential for that is 100, we're probably at like 5 right now.
You know what else is destigmatizing is coming up with a cure. So when we get, with the effort that Nancy is funding, I think we're going to get there, find a cure. And when you cure this, then people will understand it's a disease when there's a cure available.
Did you still have a question? The blonde with the white? Yeah. Okay, sorry.
You mentioned the possibility of medications that will reduce cravings. I know there's Vivitrol and Sublocade, stuff like that. But Vivitrol never worked personally for me, and I'm on Sublocade now. I know there's a huge stigma around buprenorphine in general. And also I have had to stop taking multiple other medications because they were also central nervous system suppressants, and Balsamarin was another medication that I loved. It helped a lot, but because of the contraindication, that was an issue. And so I was curious if y'all are seeing it as a possibility that there could be a medication that reduces cravings without buprenorphine in it.
So I can tell you one of my, big hope is that more people will start to look at the importance of craving. I mean, we've gotten much better at getting people off of the drugs and keeping them on substitutes that can allow them to be functional and lead, productive lives. But we still don't address the craving issue, and that's the wiring in the brain that gets at the dopamine center, and we need more research to look into that. And again, it's not going to come from NIH because they want to fund things that they're sure is going to work. It's kind of the next step. It's going to come from work that Nancy's doing and trying to address those things. So I mean, I can just tell you, I'm sorry that we don't have that yet. Right now, the drugs we have either take away the pleasure or take away the pain or add, discomfort if you drink, but we don't have anything that will address that yet. But that's coming. People are working on it, but you're right to point that out.
I think there's a lot of interest in that. So thank you for talking about this and for identifying that as a challenge. I think that's a really good illustration how we have a medication that works. Sublocade works, but it doesn't work for every part of it, right? It's the craving is still a really significant concern. And there's a lot of effort being made now to identify medications to interrupt craving, because for a long time there was an expectation that Sublocade, which is buprenorphine, would be good enough, and it's not. And I think now we finally have convinced people that it's not enough and we need to do more, right? And so I think the hope is that in the next few years we'll have a couple different pathways available to start helping.
What's interesting is that what you had said is that you can switch from one to the next. So imagine, and that's one of the things that isn't talked a lot about how easy it is often to switch one addiction to the next, but then it's hard to get off of whatever the new thing is. But imagine if there was something to switch to that actually was able to get someone hooked on something other than drugs, like exercise or something like that. That would be, so people are working on this. It's critically important, and you're just raising more awareness just by bringing it up, and that's what has to happen.
We have time for one more question. Did you have one? Yeah. Do we have a microphone? There you go.
Well, thank you so much. This is amazing. And I admire Nancy so very much for the work she's been doing in everything for decades, helping people, saving lives, improving their quality of life. And I admire you so much for that, and your leadership and your courage and your generosity of spirit, intellect for humanity. So I applaud you for that and all these brilliant people here on the stage. I have kind of a two-part question. I'm not sure to whom it's directed, but for example, you brought up the dopamine cycle, and basically as a brain dis-ease, it's just not functioning as it's intended to be, unnaturally, whatever. And is there any correlation between, let's say, like processed foods as an example, lack of exercise, like things that have naturally occurring chemicals for our brains and our bodies, that correlation between that and the susceptibility to dopamine inducing, other substances or things in this case. And like I know there's a study with like the mice or whatever, and they're given the sugar versus the cocaine, and they seem to be drawn more to like sugar, for example, versus, which is a very strange thing. I don't know if you're familiar with that. And then also, is there anything in like the prison system or in the public sector, for example, people who are incarcerated as a result of these, addictions, brain diseases, whatever, that are effective in helping to treat those inmates to be better equipped down the line or as they re-enter society, or anything that could be maybe applied in the private sector? I'm just kind of curious.
I just have to jump in. First of all, thank you for saying the things about Nancy. That was very well put. I think we have to. But what it makes me think of is people used to think cocaine wasn't addicting, and if you give it to rats, they'll press a lever for heroin until they pass out, but they'll press that lever for cocaine until they die, because they will stop feeding and stop doing everything else. Except someone had this crazy idea, which was to put them not in a cage where they just could press the lever, but put them in a habit trail where they could interact with other rats, and they stopped pressing the lever, and they went on to not become enslaved to that. So it's the cage as much as it is the drug. And to that extent, there are lots of studies that say having a purpose in life is very protective against a lot of different things in terms of health. So yes, exercise is good. It stimulates growth hormones. For the CNS, it's always the right answer for MS, whether it's fatigue or what have you. Exercise is good in that sense. But yes, what you're pointing out is that it's not just the drugs we use, it's also integrating people back into their lives, giving them a chance to, find their purpose and like those are very important points you bring up.
I can speak directly to the jail issue. So, I work a lot with folks who are incarcerated, and again, it seems it's not that fancy, but we typically folks go to jail, right? And you may or may not get started on medications, and then you get discharged any time of day or night. It could be 2 a.m. in the morning or wherever, and so you're off, and now you've either quote detoxed, or you've gotten started on medication that you have nowhere to fill. So overdose rates are incredibly high. So we just took the simple step of, well, when you go to jail, let's try to start to get to know you while you're in jail. We've all got cell phones. It's not hard, right? It's just no one had thought to do it. Like so many things in the treatment system right now, no one had thought to do it. So now, during our part of our clinic is just a visual clinic with folks who are in the local jail. And when we started doing that, our rates went from, less than 10% follow-up to more like 80%. Mm. So there's just so much, innovation in terms of using technology, being dedicated, translating these insights and to the people who need it and are at risk that just are sitting on the shelf that we can together make happen.
Thank you so much.
Well, it's just making stuff easy, making stuff easy and accessible. I just feel like everything is just so complicated. That's right. And when you need help and you're in that crisis, like I can't even tell you how many numbers. My friend who passed away, his sister, also an addict, and she was finally ready to really get sober. They called probably 200 to 300 places. Her and her other daughter called, because they were on Medi-Cal or whatever. And they found one bed, and that's where she went, and she got sober. But we just, and also, with the rats and the, and stuff, it's like community. community is everything. And that's something that I learned because as addicts, like we isolate, and we go into shame, right? It's like no one wants us around. We screwed everything up. We stole from our parents. I pawned this. I did that. No one wants us around. We can't be trusted. And I know I can't be trusted. And I'm like, and I hate myself for it. Yeah. So I just want to be alone. I want to be away from everybody. But I want to be high, of course, but when you do have that moment where you're just like, I need help, I want to get better. And then when you get released, it's like you need community. So like, recovery community is huge. We all need each other. Support from everybody else who's not an addict. It's huge. Knowing you can go to your mom and tell them like, hey, this is what I'm feeling right now. This is what's going on. And for us to just be able to, like you said, use our platform and talk about these things, because I am open about it on the radio. I've gotten sponsees because I've talked about it on the radio, lots of DMs, people calling, saying thank you. Hey, Megan, I just celebrated a year today, And so, because I'm like, I don't care. I'm like, if you think I'm weird or you're going to judge me for being sober, like, or being an addict, like, screw you. I'm just like the people who have reached out and have said thank you. And that's what you guys are going to find. Doing your podcast, posting online, telling your story, you're going to find millions of people thanking you. And that one thing that you say or post is going to make a huge difference in their life.
You
so,
never know.
Yeah.
I want to thank the doctors for being here, Dr. Kaplin, Dr. Dunn, Dr. Herring, Megan, for sharing your very emotional story. Here's Lisa, and Nancy and Isabella for sharing what you guys went through and how you're choosing to use that pain. I want you to have one final thought before we say goodbye to everyone.
Can we just also thank you for moderating?
I was honored to be here.
I was actually going to say that I've known Lisa. We had twins together at the same time, and she's just had this very celebrated broadcasting career, so many years in Fox, and she's always been the kindest, most understanding, and lovely person. I'm so happy that you did this today. I'm very grateful you handled everything really well. I can see you did your homework. Goodness. You did a lot of homework.
Taped together.
I thank you. I thank every one of you for being here. I thank the audience for being here. Your great questions, and it takes a community of people to make us take huge steps and find a way to cure this disease. But it's the leading cause of death. We have to do it. There's just no two ways about it. We need to do everything humanly possible to try to make this better. So thank you for being here.
Thank you.
Thank you so much.